Clerk. No. All right. Just rolling through the list here. 2, 3. I'm not counting enough board members just yet. We'll give it another minute. For some reason, I'm only seeing 24, and it's usually in the 40s. You can't still be hungover from New Year's, so. All right. Let's go ahead and start a roll call. Well, first, let me call to order. Are we recording? Yep, we're on the recorder. So let me call to order the January OEBB board meeting, January 7th, 2025. Time is 1 o'clock. And let's start by seeing who's here. Enrique, are you here? Don't hear him. Cheryl Berger?
Yes, here.
Here. Michelle Duberry?
Here.
Here. Sally Duelfeld? Here. Dr. Andrea Laura? Oh, Bonnie, you around?
I'm here. I'm here.
Alrighty. Tony's going to be late. Tony, are you on? Just making sure. Tony sent in a note saying he would be late. They're doing some architectural planning. Susan Miller? Susan? No, Susan. Misty cannot make the meeting today. Robert, are you here? I hope so, because we need one more. We need Enrique, Susan, Robert. Oh, I see Dr. Laura. Dr. Laura, is that you? Confirm? Oh, nope, not on. Seymour. One last call for Enrique. Oh, Enrique. Dr. Laura is not here.
I'm here.
Oh, you are here. Okay, you made it. Good. So we have enough. Susan Miller? Not here yet. Robert Young? Okay, bottom line is I count 6 of us out of 11. 1, 2, 3, 4, 5. So we do have a quorum. With that said, let's press on in the agenda for the board minutes. We have the December board minutes in the packet. And any comments about the board minutes? Any concerns about the board minutes for December? If not, I'll take a motion from somebody to approve the board minutes from December. Oh, I should turn my camera on. Whoops. Sorry about that.
I move that we approve the minutes.
I'll second
Yay.
that.
All right. The second was from Michelle, or who was second?
Sally.
Sally. Okay. So we have Bonnie and Sally. All in favor of improving the board minutes, say aye.
Aye.
Aye. All right. Most important is anyone opposed to the board minutes? Hearing none, it'll pass 6-0. All right. So that takes care of that, and we are right on time. All right. So with that said, Just checking to see if Robert joined yet, or Susan Miller, Enrique.
I did. We all went to a different link because there are two different links. So I finally
There
found
are?
the right one. I don't know if they did.
Oh, I hope. Well, interesting. I didn't get two different links.
Well, if you're on the PDF has a link, and then the actual email has a different link. So I did the PDF link first, and it didn't work.
Okay. Yeah, I just clicked on what was on my calendar. Okay. Well, hopefully that'll work itself out. All right. So does that mean Susan Miller, Enrique, have you switched over? Well, hopefully they'll join. Let's go ahead and move on with OEB, discussing OEB's value. Director Ali, please take over.
Yeah, thanks, Bill. And sorry for the link issue. We'll get that taken care of. Good afternoon. I hope everyone had a wonderful holiday season. You might remember last month we started a series of brief presentations where we highlight one specific area of unique value that OEB delivers to its members. This slide was first presented to the board actually at the OEB retreat in November, and what we'd like to do is continue to highlight areas of OEB's value on a regular basis. Last month, I began the series of presentations by highlighting the 200% of Medicare hospital pricing cap that was established in Senate Bill 1067. And this month, I would like to highlight another major provision of Senate Bill 1067, that is the legislated 3.4% premium and cost growth caps. And now the perceived value of this provision is much less of a consensus than the 200% hospital pricing cap, and some may even see it as a burden, but it certainly does deliver points of unique value within the Oregon commercial market space, and we'll touch on those areas today. So one note before moving forward is the board has talked at length about how to amend the 3.4% legislated caps. And so it brings more value by allowing for some flexibility in its application and calculation. And as you might recall, we submitted a legislative concept to accomplish that, but the legislative concept did not make the governor's budget priority list and was shelved for now. So there will continue to be a push to amend the Senate Bill 1067 legislation, but for today's presentation, we'll focus on how it brings value. Can I get the next slide, please? And one more. Thanks, Rose. So let's start with a bit of background on OEB's budget, which is comprised of two separate structures. The first is the stabilization fund, which is 99% of the budget. The second structure is the operating fund, which represents about 1% of the budget. The 2025-27 governor's recommended budget for OEB is about $2.18 billion. The stabilization fund captures all revenue and expenditures related to our benefits, such as payment of claims, wellness programs, as well as state and federal taxes and fees. Operations includes costs to operate our business, such as system programming, staff, consultant and actuary fees, and open enrollment costs. The 3.4% legislation only applies to the stabilization fund. I mean, really, the governor's office and legislature are obviously much more interested in the financial status of the stabilization fund. A couple complicating factors when we report out to the governor's office and legislature is the biennial budget period spans across 3 different plan years. So the biennial budget goes from July to June of odd years, and while a plan year is annually from October through September. Another complicating factor is forecasting enrollment over a 2-year period of time and well in advance of the biennium actually starting. So for the 25-27 biennial budget build, we actually are asked to provide them with enrollment forecasts for that period of time about 6 to 9 months ago. So it starts well in advance of the actual period of time your budget is set for. Next slide, please. Next is a bit of background on the Senate Bill 1067 legislation. In 2017, the legislature passed Senate Bill 1067, which included those two major budget tests aimed at managing state employee benefit costs. We actually often see this as one test, but it really is two separate lines of statutory language. And essentially, it applies a 3.4% limit on both PEB and OEB annual per member per month on total benefit costs. And then secondly, on premium rate growth. So this is measured using a composite rate of the average medical, dental, and vision enrollment per member across OEB. The legislature allocates our budget using a projected enrollment figure that I mentioned, and then applying 3.4% inflation per year. So general medical inflation is usually between 6 to 8% in the commercial market. So OEB is obviously very challenged every year to meet this high bar and has done a great job doing so, as you'll see on the next slide, please. So the 3.4% cap that's mandated by Senate Bill 1067 became effective in the 2020 plan year. It actually gave us a couple of years from when the bill was passed to plan on how to implement this. This chart shows OEB's history under a per employee per month cost all the way back to 2011 and how well the board has performed against the commercial market trend. This slide will actually be highlighted in our presentation to the Legislative Ways and Means Subcommittee next month. Next slide, please. So a bit more on the two tests and how they impact your work on the OEB board. The first test is, as I mentioned, on premiums. So the overall average of all medical, dental, and vision premiums cannot exceed 3.4%. The board, in your annual contract renewals, which you'll hear a lot about today, preparing for, must balance to this number. So contract renewals are settled several months before a plan year actually starts next October. So most plan year renewals start around 6 to 8% increase. So the board must negotiate downward with carriers and look for opportunities to reduce costs if needed. This could include benefit plan design changes or changes in cost sharing, such as increasing a deductible or copay on a service, but reducing benefits is usually the last resort considered by the board. And those board members that have been around and already gone through some contract renewals know this quite well. So the partnership with OEB's carriers has been vital to achieving the 3.4% mark. And, we can't overemphasize that enough, that this is really something that we work on through a several month process in partnership with our contract providers. Next slide, please. So the second 3.4% test is that total expenditures may not increase more than 3.4% per plan year. This test is applied after a plan year is over. So if you take the total expenditures of a plan year for medical, dental, and vision plans divided by the total enrolled member months to determine the overall composite rate, and you compare that from the previous year. So for OEB, the only real variable on a P per employee per month basis is plan migration, which when you set the premium rates for the next plan year, we're forecasting some plan migration, but generally the people are going to stay in the same plans, and then you have new employees come in that enroll in different plans. So there are some variables involved in that, but it's usually somewhat minimal and it's much less impactful. The second test really is more impactful for PEB, which is self-insured, and where in a given plan your claims costs can exceed premiums, whereas OEB is fully insured. So that there's a ceiling involved when you set the premiums. But the cost can fluctuate a bit from plan migration, as we've seen year over year. Next slide, please. So to recap, well, the 3.4% caps have been challenging, if not constraining, and efforts continue to bring some flexibility to the legislation. The caps have brought some unique value to both OEB and PEB, and we listed a few areas for you, such as it's provided a budgetary ceiling, which acts as an upper limit for participating entities to use in forecasting their budgets and provide stable premiums for members. We've talked about history before OEB existed. When a district would be hit with a 15% increase in a given year, depending on experience and how that could really blow their budget. So that's the second bullet, budget predictability. I think, can't be overemphasized how important that is. Reduces uncertainty and large swings in year-over-year funding. And again, this is particularly important for OEB, which is funded primarily by property taxes and general fund revenue. And 3, contract negotiations. As I mentioned, the growth cap facilitates contract negotiations with our carrier. It gives us a target and to work together to reach that target. Number 4, it's brought OEB enrollment growth and expanded purchasing power. We have a 3% increase in enrollment from last year, which is a good example of that. And then lastly, the 3.4% growth caps have supported OEB and PEB negotiations with carriers, but it also facilitates negotiations with their network providers and as a complementary provision with that 200% of Medicare hospital cap legislation. So a lot of information there thrown at you. I think the 3.4% legislation comes up in about every board conversation starting from this month through April, May. So just wanted to provide you with a bit of background, and we'll hear more about this and how it's calculated and how it's applied in the months to come. But I'd be happy to take any questions, comments.
Ali, hi, it's Enrique. Sorry,
Yeah.
I had issues logging in earlier. Hypothetical question, something that catch my eye on the presentation about the property tax funding for OEB. If the state was to use the property tax or the property tax form or collection or disbursement would have changed, what other system could fund OEB in addition to the property tax?
That's a great question. I'm not completely an expert on how school districts, local governments are funded, but I think a portion are obviously property taxes, a portion are state general fund. I know we get asked, OEB staff get asked when for budget preparation time, when they're calculating the state school fund distributions. And I know there's experts on this in this meeting that know this a lot better than I do and how that's calculated. But I think, like mentioning, employers having that understanding that consistent budget of 3.4% or called global budget, that's really important to the state as well, not just for PEB, but I think for that state school fund calculation.
Like when you say budget predictability, you're talking about school district budget, right? Or entity budget,
Yeah.
right?
Yeah.
It's a combination of property tax and income tax at the state general fund.
Yeah, that's
So
my
it's a mixture of the
understanding
two, with a set price
Thank you.
per weighted student head of population. Next up, I see Michelle with her hand up.
Hi, and thanks again this is like a really helpful context, especially for folks like me who I still consider myself to be pretty new. But I also think that any conversation about the benefit of the cap should be accompanied by a discussion about the limitations that it imposes on us and how we can, we can stay under the cap oftentimes by increasing out-of-pocket costs. And I think that's a really, really significant tension that I wrestle with all the time. And I'm not totally convinced that the 3.4% cap is on balance a good thing. It probably is, but I wrestle with it. And so the second comment I have is just about, this is like, we're talking about premium costs, and maybe it's a little different between the two carriers, but I wonder if we like collectively have influence on the actual like cost of services that are provided, and things like reimbursement rates, because I know that like there are certain things that we probably can't influence, things like staffing or payer benefits for doctors and nurses and providers, but maybe things like medical supplies, which are like kind of unregulated and out of control. I mean, I recently had to pay for a sling for my husband's, he hurt his shoulder, and it was $160 for a sling that was available for like $25 on Amazon. So I wonder if we have any influence over that. That was an OHSU situation. That was OHSU, like a company owned by OHSU that was selling medical supplies back to OHSU providers. And I sort of think that that kind of thing is happening all over the place and contributing to like the rising costs for our members.
Yeah, I mean, those comments are right on, Michelle. I mean, I think we've all experienced personally, if not professionally, the costs are soaring right now. We read it in the news right now. There's a lot of pressure in various parts of Oregon's marketplace, and a lot of kind of stalemates in contracting. And thankfully, those haven't impacted PEV and OEBB, but I think you'll hear in the next presentation from Mercer that looks at the landscape for this upcoming renewal, and there's going to be pressures, that I think we've experienced in the last year, but it's also pressures that the board has been able to overcome, in years past. So as far as leveraging negotiations at that level that you spoke of personally, I don't know that we do have that kind of leverage, but I think that with greater enrollment and greater purchasing power comes obviously greater leverage to give our carrier partners the ability to go out and get the best deal possible for our members. So yeah, I think OEBB's big enough that there is leverage, certainly, but at that level, that's debatable.
Cheryl. Cheryl, is your hand still up? Sorry, it disappeared on me.
Oh, sorry. Probably need to take it off mute. Sorry. Anyway, Ollie, you had mentioned in your discussion a 3% increase in enrollment from 24-25 year, or maybe it was 23 to 24. But that said, you also just mentioned greater enrollment equal greater purchasing power, that sort of stuff. Is there a possibility, or is there an opportunity for us to look at the list of other organizations that are participating members? And I asked that question just because from a county perspective, are there other counties that I might be able to visit with or encourage that sort of discussion. I know we talked about having you guys at AOC this past year, but I wonder if there isn't an opportunity for a little bit on my part as well.
Yeah, absolutely. We'll have some open enrollment presentation later today. We definitely have demographic and participating entity data that we can provide that we'll make some time on a future board agenda, and so you can kind of get the landscape of the state and where OEB's presence currently sits, and maybe look from 3 or 4 years ago to where it is today, and maybe some of the changes across the state. If that is helpful to you, Cheryl.
Yeah, it is. Thank you very much. I appreciate that.
You bet.
Yeah, and a comparison with CIS would be, I don't know how you do that though, but a comparison to
we can't.
CIS.
Yeah,
That'd be
and
good.
we can, and I have in the past anyway, when we've had our personal team members ask us to do a comparison so that we can understand whether we've got, the good rate, if you will. And so, yes, we certainly can do those pieces of information. And I will just share that the last time I did this, which was been 2 years ago, it was an obvious expense increase. I mean, huge. So.
That's good to know.
All right. Any other questions for Ali?
Yeah, and feel free if you have any other
Yep.
questions, you can always email me. Any specific questions or things that come to mind after the board meeting.
Excellent.
Thank
All right.
you.
All right, we're just a little behind, no problem. Let's move on. Mercer's presentation on OEB open enrollment report with Kirsten.
Cheryl and Ollie, thank you for the perfect segue into the OEB open enrollment results. So this report, it's the same format that we looked at last year, and we'll look at enrollment trends with OEB, eligible subscribers, enrolled subscribers, and entities for medical, dental, and vision. And as Ollie mentioned, I know we know this too, OEB's plan year is effective of October 1st each year. So these enrollment results compare enrollment as of the October 1st census. So Rose, thanks for running the decks today. And next slide, please. And one more, one more. Thank you. So we currently have 256 entities participating in OEB. By entities, we mean a combination of school districts, local governments, and also special districts like hospital districts. That's an increase of 3 over the last time that we went through this report together. OEB has about 71,000 eligible subscribers, and of those eligible subscribers, 57,000 of them are enrolled in medical insurance through OEB. OEB offers a choice of 11 medical, 7 dental, and 6 vision plans for employees to choose from. Those are offered by Kaiser, Moda, BSP, and Willamette Dental Group. Our mix is about 75-25 rural and urban. We have a tiny bit of enrollment outside the state. Those are mostly dependents who are off at college. Next slide, please. We wanted to juxtapose the enrollment distribution by state with the entity distribution by state because there are just a couple interesting differences. So on the left, that's the distribution of medical enrollment by region. And this is a mapping of region we've worked with staff to put together over the last few years. And you've seen this before. It just helps us think through maybe counties in one region are facing similar healthcare challenges. And so when we look at enrollment or even clinical outcomes, sometimes by region, we can see things we don't see when we look at overall statewide totals. So you'll see on the left, when we look at enrollment by region, oh, hi, Robert.
Sorry, I might be premature on this. I just want to say I love this graphic, and maybe in the future we could have one that's similar in structure, and it shows the number and percentage of providers.
Yeah, thank you so much. We'll take that away. Yeah, we can work with the carriers to do that. That'd be interesting. So on the left, we have medical enrollment by region. So you can see just a couple things immediately pop out, right? That between Metro, so Portland, Beaverton, Hillsborough, Southwest Washington, that area, Metro has 37% of the medical enrollment, followed closely by Willamette Valley, which is 28.2%, and the Bend Central Region with 6.6%, Southern I-5, 12.8%, and then the coast with 5.8, Northeast Oregon with 5.5, and Southeast with 1.8. And the major differences on the right really have to do with entity size and how that comes into play. So you'll notice that if we look at the number of entities by region, between the coast and Northeast and Southeast, we have about 38% of the entities in that area, whereas we only had about 13% of the enrollment. And that just has to do with many small entities in the more rural parts of the state joining OEB. Rose, next slide, please. For the overall results, as Ollie mentioned, we had solid growth again in OEB for the second year in a row. So the medical line of coverage saw 3% medical growth, dental a tiny bit higher with 3.1%, and vision growth with 3.5%. Kaiser grew 1.4% compared to MODA at 3.6% on the medical coverage. And just as a reminder for our new board members too, not every plan and carrier is offered to every employee across the state. The choice of carrier and plan is actually made at the entity level. So entities can choose whether or not to offer MODA or Kaiser or both. And then once they make the decision to offer a choice of a carrier, they can also decide to offer which plans. They don't have to offer all. And of course, where the entity is located in the state makes a difference too, because the Kaiser service area is not statewide. For the dental growth, we had 2.2% in Kaiser, 3.5% in Delta Dental, 2.1% Willamette Dental. So growth overall with all the options. And then vision, a small growth in Kaiser, roughly flat for MODA, small decrease. And then VSP grew the most with 10.6% enrollment growth. Next slide, please, Rose. Again, the PPO and HSA plans lead the medical growth. So with the PPO plan, I'm looking at the medical enrollment growth total. About 60% of that was in the PPO plan option, 15% in the HMO option that's offered through Kaiser, and about 23% offered enrollment growth in the HSA plan. That's consistent compared with last year too. Next slide. Again, same as last year, the dental growth was seen primarily in the plans that offer coverage for orthodontia. They don't all offer coverage for orthodontia. And the plans with ortho increased at 3.5%, while the plans without orthodontia coverage increased at 1.2%. And the plan mix stayed pretty consistent compared to last year at about 80-20 with and without ortho. Next slide. So when we think about the medical enrollment growth, that was driven by primarily Medford School District, which was one of our 3 new entities this year. And that is why the Southern I-5 corridor leads the enrollment growth with about 1,000 subscribers. There was some enrollment growth in the metro area as well, about 150 subscribers in the medical plan. And then in Northeast Oregon, about 150 new subscribers as well. Next slide, Rose. Again, so I-5, the growth in I-5 was driven by the Medford School District. The Medford teachers joined OEB and offer medical, dental, and vision coverage. And this graphic is just illustrating that of the growth in the I-5 corridor, about 95% of that was due to Medford School District. Next, Rose. We like to include an enrollment slide just on Senate Bill 551 because we're monitoring it and expanded coverage to a group of employees that was not formally eligible for coverage. We're seeing small enrollment in that still, but we do like to track it. So about 2% of the medical growth was enrollment in the Senate Bill 551 plans, and that was similar for dental and vision as well. Next slide. So now we'll dig into a little bit more of the detail, and we'll talk about medical enrollment by plan, and we'll do the same thing for dental and vision as well. So just one note about terminology and how we've organized this slide. So we saw on the very first overview slide that OEB offers 11 medical plans, 7 dental, and 6 vision. So it's a lot of plans to keep track of and lay out on a table like this. You'll see a little bit of terminology under the plan name. LG is just, that's the category or the line for enrollment. That's not school district related. So we've put local government and special district enrollment together into that line. And that's just simply for informational purposes. There's no difference in plan design or anything like that. It's just so that we can see enrollment and how it's been changing. One other note about these plans, maybe a couple more. The plans are numbered both for Kaiser, plan 1, 2A, 2B, and 3. And then for MODA, the plans run 1 through 7. And the lower number the plan, the richer the benefit design, which means the lower the deductibles, out of pockets, copays, and coinsurances are. With that comes a little bit of a caveat, however. Some of the higher deductible plans, like MODA plans 5, 6, and 7, can be paired with an HRA or an HSA. Those are controlled and funded by the entities, and we have limited data on the amount of those, so that to the extent that those are partially or fully funded would make those plans actually quite a bit richer than they just appear on paper. We like to keep in mind plan richness as we're looking at enrollment, and also PPO versus HMO versus HSA to see what kinds of plans are interesting to our members. Where are we seeing enrollment changes year to year? Is there anything that we should investigate further? So this is just sorted by Kaiser and MODA, and then by plan, really by plan number / plan design within that. So we can just see a couple of the bigger changes. Kaiser Plan 1, overall enrollment growth of 200 people. There was maybe a shift in enrollment from Plan 2A to Plan 2B. And then MODA Plan 1 also had significant enrollment growth, 342 employees. This tells us that the employee premium / employer contribution relationship, at least at some of the entities, is enabling members to be able to afford and enroll in the richer plan premiums. MODA Plan 3 grew 243 subscribers. MODA Plan 5, that's the one that can be paired with an HRA, grew by 293 subscribers. And MODA Plan 7, which is an HSA compatible plan, grew by 429 subscribers.
Or people just like odd number plans and don't like even number plans.
Or they're tax savvy and take advantage of the tax advantages of an HSA plan. Rose, next slide, please. Great, so this is the exact same information, but we've just sorted it a little bit differently to show you how much premium is attached to each plan, and then which plans had the biggest change. MODA Plan 7, the HSA compatible plan, had the biggest change with an increase of 429 subscribers. But then Kaiser plans 2A, 2B grew, and 2A had the enrollment decrease, a little bit of a shift in enrollment there. And then for MODA, interestingly enough, the next biggest enrollment growth was plans 1, 5, and 3. And then if you're curious, we have the premium attached to those plans off on the right. And just to put it in perspective for you, OEB has surpassed 1 billion in premium total. So those numbers are fairly big. Rose, next slide. Next, we'll look at medical enrollment by OEB healthcare region, and then we'll look at the change and the percentage of total change for that region. We've really touched on the major highlight here already, which is that due to the addition of Medford School District on 10-1, the I-5 Southern Corridor has the most growth with 16.9% of the enrollment growth. And that's an increase of 1,054 subscribers, followed by Willamette Valley and Northeast and Metro had enrollment growth as well. Next slide. Dental enrollment by plan, same thing. Here we're looking at the September to October enrollment and any major changes that occurred. So Delta Dental Premier Plan 5 with orthodontia coverage included had the largest increase with 948 employees added, followed by Premier Plan 1 also with orthodontia coverage had an increase of 458 employees. Kaiser increased by 179 employees, followed by Willamette Dental had some growth as well. And then the Premier Plan 6 with Delta Dental. Next slide. This pie chart shows the distribution of dental enrollment by plan. Just another visual to illustrate where the enrollment mix is concentrated. So the biggest piece in the bottom right, that big pink slice, is Delta Dental's Premier Plan 1 with orthodontia, followed by Premier Plan 6 with 18.1%, Premier Plan 5 with orthodontia coverage, 13.1%, and then Kaiser and Willamette Dental both have around 14-15%. And then the other two plans are smaller Delta Dental plans. There's an EPO plan. EPO meaning exclusive provider organization, has a slightly smaller network. And there's one that's an incentive plan design, which means every year you get your preventive care. The next year your benefit's a little bit better. And the other one is just a straight PPO plan with orthodontia included. Next slide. Vision enrollment by plan. Both of our major medical carriers, Moda and Kaiser, often offer vision coverage. And then there's a third option as well, VSP, which is a standalone vision provider. So if we look at the enrollment change, VSP grew by 1,633 subscribers, followed by Moda's Opal plan with 251 subscribers, and Kaiser's plan as well, which is embedded with the medical plan, grew by 140 subscribers. And overall vision enrollment grew 3.5%. And again, we'll look at the distribution of vision enrollment by plan. It's more of a visual look at things. The Opal plan in the bottom right with 32.9%. That's one of Moda's 3 plans, followed by the Choice Plus plan with 23.9%. That's one of VSP's offerings. Kaiser Vision is the third most enrolled in vision option with 17.2%. And then next we have the other 2 remaining Moda plans, Quartz and Pearl, and VSP's other vision option, the Choice plan with 7.4%. Great, so now we're going to look at the September to October enrollment trends and looking to see if members switched between carrier and plan. And we did this last year for the first time and saw that last year about 80%, slightly more than 80% of employees stayed with the same carrier. This year it's actually a little bit, well, quite a bit greater. So looking at the medical renewal decision, so these are employees who were enrolled in September and also enrolled again for October 1st. Did they stay with the same carrier? So looking at their medical coverage choice, actually about 98% of employees stayed with their current choice of carrier. On the dental, it was 97%, and on the vision, it was 95%. So the vast majority of people are re-enrolling with their current carrier. And then we also have 2 other little pie slices. One, of course, is switch. So they were in Kaiser and they switched to Moda or vice versa. But then every year we do have people who disenroll for various reasons. And that's represented by those smaller pie slices as well. Next slide. And so now looking at people who enrolled with their same carrier, now we're interested to see if they enrolled in the same plan or did they switch to a different plan. We use the plan terminology richer and leaner to refer to the cost share. If the cost share is lower, meaning the member pays less for their medical care, we say that plan is richer. And if a member's copays and coinsurance go up, we say that plan is leaner and the member has to pay more out of pocket. So the vast majority of employees actually enrolled with their same plan. So same carrier and same plan. 93.3% for Moda and 93.5% with Kaiser. And then of the people who switched, it was about even who moved to a richer plan versus a leaner plan. And lots of things can influence that decision. For example, each year when employees make the enrollment decision, they're thinking about how many dependents are they covering, because that's going to determine their premium amount. And then, of course, the other big component of that is what is their entity going to contribute towards premium? And then the employee is also thinking in their mind, how much medical care are they going to be using that year? So there's lots of factors that go into the decision to either move into a richer plan or a leaner plan, or even just stay in the same plan. Next slide. And one more. Thank you. So looking at entities now, and we're looking at employees who have enrolled in the different plans that were offered by their entities. I guess if an entity offered a plan and nobody enrolled in it, we wouldn't have a record of that because we were looking at the open enrollment census, which showed which plans employees enrolled in. So just looking at that, the employees enrolled in the various plans, and then what entity are they a part of? We see some really interesting trends. So for Kaiser over on the left, this is medical now. For Kaiser, 43% of the entities offering Kaiser offer all 4 Kaiser plans. And for entities offering Moda, 39% of the entities offer all 7 of the Moda plans. And then if we look at the 3 or 4 plans for Kaiser, 73%. And for Moda offering a choice of 6 or 7 plans, is 52%. So in other words, the majority of entities are taking advantage of OEBB's broad range of plan choice. Looking at the dental plans offered, there are 7 dental plans between Willamette Dental Group, Kaiser, and Moda. So again, 17% of entities offer all 7, 28% of entities offer 6, and 18% of entities offer 5. So the majority of entities, again, taking advantage of the dental plan choice. And we see the exact same thing. When we look at the vision choices, there are 6 total between BSP has 2 and Moda has 3 and Kaiser Permanente has 1. So again, the majority of entities are really taking advantage of the vision choice and offering 4 or 5 or 6 different plans to their employees. And Rose, next slide, please. We have one more. We also just wanted to show you, because it's hard from the data that we've seen so far to get a feel for the entities themselves. So we just wanted to show you a little bit more information about the entities and how big they are and how many of them are there. So we know there are 256 entities now as of 10/1, and those entities actually range in size from 1 enrolled employee all the way up to 4,344 employees enrolled in our biggest entity. So the graphic on the left is showing you entity size, that's along the x-axis, and then the percentage of total enrolled employees and the percentage of total entities that are in that entity size category. So for example, 39% of entities actually have between 1 and 50 enrolled employees. And all the way on the right, 4% of entities have more than 1,000 employees enrolling. But of course, those largest entities have a bigger proportion of the enrolled employees. So 34% of enrolled employees belong to an entity that has 1,000 or more employees enrolled total. So this is just interesting. We're always balancing enrollment and the individual with also our entity needs and our entity distribution statewide. And I believe that was the last slide. Rose, if you'd advance one more, we can, confirm. Thank you so much. Any questions?
Board members? Very interesting. Migration data was very interesting to me. In the fact that people are staying home. They're in a situation that they're okay with at a minimum. I don't see any hands up. I saw you just take a quick swigs because you're up next again, Kirsten, for the renewal primer. Should we just jump right in?
Yeah, let's do it.
Bring in your buddy John.
Yeah,
Get some
thanks.
numbers.
No numbers.
No numbers.
Mostly theory, I think, and some prep
Okay.
work. Yeah, thanks.
All
If you'll
right.
advance to the next slide for us, Bill. So welcome and Happy New Year, everybody. It's great to see you again. And we wanted to have this opportunity to have a presentation about future upcoming presentations because they just are so critical now, February through April. Board members who have been with us before through a renewal cycle will tell you that a lot happens between February and April. We go from seeing everything for the first time to seeing everything for the last time and making final decisions in the span of 3 meetings. So between February, March, and April, we're going to evaluate the proposals that we're getting back from the carriers this week. We're going to negotiate higher value. We're going to balance our options and make all final decisions. And the cutoff for that, just the way the calendar falls, April 1st, actually, the very first Tuesday of the month is April 1st. That will be our cutoff for final decisions. So your input as the board impacts OEB members and communities statewide. And we are hoping that this renewal primer will prepare you to be an active and informed participant in the next few months. And please, as always, ask lots of questions. Next slide, Bill. I just wanted to level set before we get into the details, both in this presentation and this meeting, but also the details around the renewal in February, March, and April. I just find it so helpful to level set ahead of time and remind ourselves why we're here, because we're going to get into the weeds about financials and trade-offs and lots of details. But there's a really big, important picture for why we're here together, right? We're here to achieve OEB's mission and OEB's vision and your new board goals that you set in the recent retreat this fall. And then even above that, we're here together to improve the health and the well-being of Oregonians. And OEB's reach is so broad. Not only do you impact OEB members and their families, but we have local governments and special districts participating in OEB. So those members and families. And then, for example, with the doula benefit, which is innovative in the state of Oregon, when we do things for our members within OEB, often they have a ripple effect and impact communities across the state of Oregon. So in that sense, the work that you do has the opportunity to touch every Oregonian. Next slide, please. And let's just level set. Also, I wanted to consolidate this on one slide for you so you could print this and have it later. But we can quickly refresh our memories on OEB's vision and mission and then our new board goals. And I really love the way it's spelled out on OHA's website, and thanks to the OHA team for their excellent work putting that together. But OEB's mission is to help people and communities achieve optimum physical, mental, and social well-being through partnerships, prevention, and access to quality, affordable healthcare. The Oregon Health Authority, which oversees Medicaid, OEB, and PEB, and we saw last month that encompasses 38% of Oregonians together. OHA will transform the healthcare system in Oregon by improving the lifelong health of Oregonians, increasing the quality, reliability, and availability of care for all Oregonians, and lowering or containing the cost of care to be affordable to everyone. OEB's vision is that OEB will work collaboratively with districts, members, carriers, and providers to offer value-added benefit plans that support improvement in member health status, hold carriers and providers accountable for outcomes, provide affordable benefits and services, support Oregon's health system transformation efforts to promote better health, better care, and lower costs, and to embrace the coordinated care model of delivery. In the OEB retreat this last fall, you as the board voted on 5 new board goals, and they were to provide high quality, affordable care to members and their families, to grow OEB membership by attracting more school districts, local governments, and special districts, reduce out-of-pocket expenses for members, explore an RFP, and continue to work on providing member education. So we'll come back to these. I know we come back to these a lot during our presentations with you. And we'll come back to these again and again in our meetings, February, March, and April, to make sure that we're in alignment and we're achieving what we set out to achieve. Next slide, please. All right, so where are we in the renewal timeline? So if we think about our work with you starting in October, we got a little bit of a late start this year because there was some timing issues, so we missed the September meeting. So we all jumped right into it in October, had our retreat in November to set goals and talk a little bit about the strategy for the renewal. Once the retreat was completed, there was a lot of very vigorous and quick work behind the scenes to translate all of your vision and strategy into renewal letters that went out to the carriers. And those are going to come back this week. So there's been a lot of preparation to evaluate those. In this meeting today, we're talking to you so that you are also going to be ready to evaluate those. Together, we're going to do that in the February and March board meetings, evaluate and negotiate improvements in the proposals. And then we'll all come back together in April and see final proposals and make final decisions about what's going to be implemented on 10/1/25 for the next plan year. Next slide. Let's do a quick recap leading up to today, what has already been talked about. And we'll do this pretty briefly, and then we'll talk about what's going to happen in the February through April meetings. So in our very first meeting together, October 1st, 2024, we had some introductions and an orientation to OEB. We went through an OEB overview and talked about how OEB got started. We introduced the OEB value slide, which Ali has deep dived into with you now for a few months. We looked at the evolution of the board goals and some key collaborations with your carrier and vendor partners, OEB subcommittees, our staff. And then we recapped some recent renewal decisions for the last 2 years, especially focusing on clinical decisions and looking at the evolution of all of the things that you've done to improve our treatment options for cardiometabolic disorder and to close gaps in care, and then also highlight how we've met 3.4%. In November, we got to meet each other in person for the first time at our retreat, where we recapped the different ways that the previous OEB boards have achieved the board goals that were in effect at that time. And then, of course, you set new board goals, and we talked through some clinical renewal strategy priorities. In December, you met your carrier partners, MODA, Kaiser Permanente, and Willamette Dental Group. We heard from Ali about the 200% of Medicare hospital payment cap aspect of OEB's value, and heard from John Kessler about some benefits benchmarking. And then many of your support team were working behind the scenes to develop the renewal letters for you. Today, January 7th, oh no, it should say 2025. We're preparing for the February through April renewal meetings with this renewal primer presentation. And then we're going to talk about how you've already achieved one of your goals. You saw that with the open enrollment presentation, with enrollment growth of 3.3% as of 10/1. You're going to hear from Delta Dental and also vendor satisfaction results. And also behind the scenes, there's been continued work around the renewal letters and getting ready to receive the proposals, which are coming in this week. Next slide. So we're calling this a call to action, because we know it's a big time commitment for you, the board members, to set aside time from your day jobs to attend the board meetings and participate. And we know that, that's a big time commitment every month. We just wanted to highlight there are a couple opportunities throughout the year that are bigger than the other ones. The first one, of course, is the in-person retreat where we all get to meet each other and set new board goals and strategize about the upcoming plan year. But then also February through April, those renewal meetings are really key opportunities for you to advocate on behalf of your members. You're going to help us evaluate the proposals through your members' eyes and negotiate better value with our carrier and vendor partners on behalf of your members, and help us balance the diverse and often competing needs of your members. Next slide. So let's look at what's coming up. In February, we're going to evaluate round one. So in December, we issue a renewal letter every year that says, hey, carrier and vendor partners, we want you to give us your round one proposal for, and then we list a bunch of things, all of the clinical ideas that we've talked about in the retreat with you, any other changes that have been discussed with you from prior years that didn't get executed yet. We ask for the first round of financials, the premium increases, for example. And then the carriers send those back to us. That's called round one. And we're going to get that back this month, this week actually. And we'll evaluate and prepare presentations and make all that ready for you to see. And you'll see that at the February meeting on February 4th. And in that meeting, we'll talk with you and have a big group discussion about how we'll assess those proposals and look at the quality and equity and value and cost, and decide how we want to go back to the carriers and what we want to ask to have be better. That will happen in early February. And then in late February, we'll get round two, the response to that. We'll get round two back and bring that to you in the March 4th board meeting. So we'll do the exact same process again. We'll evaluate round two. Did the carriers do what we asked with the financial proposals, with any program or benefit changes or clinical proposals? What do we still want to negotiate to be better with our carrier and vendor partners? And then behind the scenes, Mercer will write the renewal letter and send that off to the carriers and get round three, the final renewal response, back in late March, in time to put all of those materials together and bring them in front of you in the April 1st meeting. Together as a big group, you'll evaluate round three. You'll look at the final premium rates and all of the different options and benefits and programs and how the premium rates would change with those included. As part of that discussion, we'll be balancing adding new benefits and programs, maintaining existing benefits and programs, protecting and premium affordability. And then you'll make final decisions on whether to renew or terminate any existing benefits or programs. Do we want to change anything? And then which of the new options, there are always many exciting options to consider, which of the new options do we actually want to put into effect for 10/1? That will all be decided on April 1st. Next slide, Bill, or Rose, I mean. So let's talk a little bit about what it means to evaluate a proposal, and then we'll look a little bit more in depth too at the process of negotiation and of balance. The proposal requests were sent to the carriers and vendors on December 6th in something called a renewal letter. And the renewal letter is just a written documentation that reflects the goals and priorities that you, the board, set at the retreat. And those responses are due back to us on January 8th. The proposal that we're going to get back will include premium changes, the carrier suggestions for increasing the value of existing benefits and programs, and also ideas for new benefits and programs. The proposals reflect a collaborative effort between you, the board, of course, with all of your input at the retreat, our carrier and vendor partners, OEBB committees, OHA staff, and your consultant team that's supporting you too. The board will evaluate round one proposals and request modifications, which will be sent to carriers and vendors in the round two renewal letters in late January. For proposed premium changes, by evaluate, we mean scrutinize the method and assumptions for soundness and reasonability. For proposed changes to existing benefits and programs, by evaluate, we mean assess the member impact and opportunity cost. And for proposed new benefits and programs, by evaluate, we mean assess how well proposed ideas meet the goals and standards that you as the board have for quality, equity, value, and cost. The evaluation results then directly lead into the negotiation process with our carriers and vendors. Next slide, Rose. So let's talk a little bit about the negotiation process, which is this back and forth with our carrier and vendor partners to push them to improve their proposals for us. So the proposals are improved on through an iterative process of evaluation and negotiation, and these happen publicly in our board meetings. Again, we have February, March, and April for these discussions to happen. And when we say negotiate for improvements, we really mean advocate for better benefits, lower costs, and higher value for your members. Mercer leads those negotiations and uses a few different strategies, including market intelligence. So for example, how do the current or proposed benefits compare to benchmark? We also independently validate costs and other things that are provided by your carriers. And we look to see are promised clinical outcomes likely to be achieved? Are rigorous standards for equity likely to be met? Are the program costs relative to proposed outcomes going to produce high value? And overall, does the proposal achieve OEB's mission, vision, and goals? And then we also operate as a sounding board for the carriers and vendors to suggest alternate ways of calculating or looking at things that can help move initiatives forward. Successful negotiations reflect the strength of Mercer's relationships, benchmarking data, financial acumen, clinical expertise, as well as the commitment and partnership of your carrier and vendor partners, and of course, your participation and commitment as the board. Next slide. I know we've talked a lot about this today as well. Ali's presentation talking about the 3.4% cap, and then Michelle, thank you very much for your comments as well. We're very sympathetic to the trade-offs with 3.4%. I think the open enrollment report illustrated some of the benefits of the 3.4% cap. Through stability and affordability, we can have growth within OEB, which is one of our goals. Of course, it's not our only goal. And I know that sometimes 3.4% can appear as a constraint. And so we just wanted to acknowledge that upfront and reiterate our commitment to approaching 3.4% with compassion and keeping the big picture in mind, which is that sometimes we have to talk about financials, but we always are remembering that there are members with health conditions, and we are working, just like earlier, that slide, we are working to improve the health of all Oregonians. And sometimes that means adding important benefits as well. So there is a balance, and we'll talk a little bit more about that, but we really just do want to reiterate our commitment to considering, all aspects of this. Next slide. On April 1st, we're going to make decisions around what's going into effect on October 1st, 2025 for the 25-26 plan year. And in that meeting, we're going to need to balance many options. I was going to look up some statistics around just how much money there is in venture capital going into healthcare. It's in the many, many billions of dollars, which of course is very exciting. It means that healthcare transformation, which is part of OEB's mission and vision, healthcare transformation is not hard. What's hard about it is choosing between the many different options, which is something that we do every year with you. And there's always a trade-off between how many new things do we add and how many of the current things do we keep, so that overall we balance a commitment to health and equity and well-being and innovation, and simultaneously a commitment to affordability as well. So some of the considerations that we'll all think through together would be, how does a benefit or program help the board achieve its goals? Will a benefit or program have higher value in the future? Does the benefit or program change align OEB with the market? How does the cost compare to the available benefits budget? How does the impact of one option compare to the impact of another? And can additional benefits budget be freed up to pay for a new benefit or program without compromising OEB's market competitiveness? So just some of the things that we'll all think through together in the upcoming board meetings.
Very good. Let's open the floor for questions from the board members. Please raise your hand. I assume there's going to be a couple questions on this. It was pretty thorough, and appreciate all the work you put into that, Kirsten. That was a really good, thorough analysis on how we go about our front half of the year business, calendar year, that is. Right.
Thanks, Bill. Thanks also to John. He didn't have a speaking role, but of course, he's instrumental in helping to put all these together too, and the Mercer team.
Yep. So thorough that I'm not seeing any hands. Right. Yeah. So definitely the process of going through each round of negotiations is quite a challenge. And in the end, it's always very difficult to vote on the scenarios that Mercer presents, on the options of what we can do and not can't do, or how we move things around to stay in our cap, but yet provide that quality service. Ali, I see your camera just popped. You got something you want to chime in on?
I kind of mentioned this earlier, but just want to reemphasize, that we're here for you as board members. So as we go through the next few months, please always feel free to reach out with any questions, or even just to go over, a previous presentation, some points of it. It's going to be very confusing. I mean, this takes years to really learn and understand. So we want you to feel confident that you're making the right decisions and have the information that you need to make those decisions. So please don't hesitate to reach out to us. So we're here for you.
And I'd like to just state, on the record, something that we all know. Every year I'm kind of a little jealous of the PEP people who get one contract for state employees and get a common benefit across their entire membership. We have an extremely diverse set of things we have to deal with, from, full range of payroll in our membership, from all the different districts that handle how they do the benefits and how they contribute to employee benefits differently that we don't even have access to. And all these different variations that come across in the OEB decisions that the board has to make and cover, yet do the best for everyone that you can in one set of choices, with an extreme diversity of membership. So it's always the challenge for us as OEB members. Just putting that on the record. We all know that, right?
Well said. Yeah.
So, but we are about 15, 20 minutes ahead of schedule with this. Why don't we go ahead and take a quick break now? Let me just do some mental math here. Let's come back. Who's next? Up next is Delta Dental. Terry, are you here? Are you here yet? I know we're a little early.
I'm here.
Yeah, could you be ready to go at 2:25
You betcha.
instead of 2:45? Okay, let's come back at 2:25 and we'll have Delta Dental present. All right. So short break. See you at 2:25. All right, everybody. We have, can't look around the room. Show of hands. Close enough. All right, I believe this next presentation is because we ran out of time at our last meeting. This is to catch up on the last one that we didn't have time to do, which was what we were talking about in the last meeting, carrier innovations, each carrier going through each one, Delta Dental, getting their turn now. Let's see, Terry, are you back with us?
I am.
All right, why don't we go ahead and get started then?
Terrific. Thank you. Really quickly, just as an introduction for anybody that I have not yet met, I'm Terry Barrichello. I'm the Vice President and Chief Dental Officer for Delta Dental of Oregon, and I'm very happy to be here today to talk to you about some of our innovative programs and initiatives that we've been working on. You can go ahead and go to the next slide, please. So you can see from the topics on my agenda that we have been focused on access and equity for underserved populations and medical dental integration. And as I go through the presentation, I think you'll also see that we have been focused on leveraging strategic partnerships in several of these endeavors. You can go 2 slides, I believe. Perfect. So I'm going to begin with teledentistry. The public has been, I would say, not just accepting, but actively interested in mobile and telehealth options, and as evidenced by the stats that you see on the slide. Despite this, dentistry can sometimes be a little slow to adopt new concepts. Teledentistry has been around for quite some time, but has not widely been put to use. Fortunately, though, the modalities for interacting with patients remotely and securely have greatly expanded in the last few years. That, coupled with the pandemic, created an opportunity to change the way the dental profession views it. Use of teledentistry happens in one of 2 ways. There's synchronously, which is a real-time interaction using phone or video conferencing, kind of like what we're doing right now, or asynchronously, where clinical patient data like radiographs, photographs, and perio charting can be collected at a location away from a traditional home setting and a dental home setting. And then this information, it can then be later reviewed by a licensed dentist. I'm happy to say there is increasing evidence and growing acceptance by the dental profession of the accuracy and validity of these remote interactions. There was even a recent study that showed that even dental students using teledentistry were able to detect healthy structures with a 99% accuracy and dental cavities with a 74% accuracy. And that was using digital photos taken by the patient. So basically, using your own phone and trying to capture what's going on in your mouth. So it's pretty impressive. There are a myriad of ways that teledentistry programs can be designed and employed. And I'd like to show you how we're approaching it at Delta. So go ahead and go to the next slide. Perfect. We've prioritized certain solutions and benefits for our members. Our objectives include 24/7 access to care regardless of location. We're interested in both synchronous and asynchronous solutions to facilitate anything from screenings, triage and advice, and we want it to be really easy for our members to utilize. So we're doing it through 2 pathways. The first is a community-based approach. Patients can receive preventive and early intervention therapeutic services in community settings. Our hygienists and assistants are in the field, and technology links them to our dentists and traditional clinics. And I'm going to talk about that more in the next slide. And then secondly, we're working now to finalize an agreement with a teledentistry vendor, and through their platform, our members would be able to schedule video and phone appointments with licensed dentists across the US and around the clock. For both these modalities, again, we want it to be easy for members to be able to navigate. And then really important to me is that we want to ensure that they're subsequently connected to in-network providers for the definitive treatment, restorative surgical care when needed. Go ahead and go 2 more slides. Perfect. I'm going to first begin by explaining, actually on this slide, who and what Aero Dental is, that pretty little logo on the top right. In addition to our commercial Delta Dental business, we also administer the dental Medicaid benefit for over 340,000 Oregonians covered by the Oregon Health Plan. To ensure access to care, we've grown our operations to include dental clinics, and it's under the brand Aero Dental. And we've increased our footprint, and we now have 9 locations across the state focused on serving Medicaid patients. And beginning last year, our Aero clinics have expanded to include community programs. And that team includes 4 expanded practice dental hygienists, or EPDHs, 2 dental assistants, and an administrative coordinator. And they're currently serving 23 schools in Baker and Harney counties and 27 schools in Columbia and Clatsop counties. They provide oral health assessments, fluoride treatments, oral health education, nutritional counseling, and then they also coordinate referrals for that definitive care when that's appropriate. The program thus far is focused on meeting the needs of children in rural locations, but our intent is to grow over time. In addition to seeing kids at schools, preventative services and care coordination are offered 1 day a month to WIC clients at the Baker County Health Department. And this is our newest effort. We just began doing this in June. Go ahead and go to the next slide. One of our very valuable partners has been OHSU. We have a couple initiatives underway with them. We kicked off a medical dental integration project last year aimed at providing basic oral health services on site at a pediatric primary care clinic. This is also accomplished through our Aero Dental clinics. We have an EPDH on site at Hillsborough Pediatric Medical Clinic 1 day a week, offering those same preventive services that we offer in schools. In this program, a very large effort is made to help parents navigate getting connected with the dental home for their children. Sometimes they have Medicaid, and that can be a little easier. Sometimes they don't have any dental insurance at all, but we try to make sure that we're doing that warm handoff to definitive care. Go ahead and go to the next slide. And the next one. Thank you. I'm excited to talk about our newest medical dental integration effort that's under development. We're partnering again with OHSU to conduct a diabetes screening study with Aero Dental patients. Go ahead. Oh, thank you. We're already there. A little background on diabetes and oral health. There is a bidirectional relationship between diabetes and gum disease. And by that, I mean each disease state has an impact on the other. So diabetes lowers the body's resistance to infection, which makes diabetics more susceptible to developing gum disease. Studies have shown that for every 1% increase in hemoglobin A1C levels, the odds of periodontitis or gum disease increase by 18%. For diabetics who develop gum disease, its progression can be aggressive. Conversely, studies show that type 2 diabetics that have gum disease, but they get periodontal therapy and have regular maintenance, they can improve their glycemic control and lower their A1C levels. According to the American Diabetes Association, in 2021, over 38 million Americans, which is over 11% of the population, had diabetes. And of that, 8.7 million of them didn't know, and they have not been yet diagnosed. It's also estimated that over 97 million people have prediabetes, and alarmingly, 81% of them don't know they have it. So there's an urgent need to help connect these people into care. According to the AHRQ, the Agency for Healthcare Research and Quality, in 2019, over 28 million Americans reported having visited only a dental provider in the last year, meaning there was no interaction on the physical health side. So you can see that this is an area rich in opportunity to make a positive impact on both oral and overall health. So go ahead and go to the next slide. So we are partnering with the OHSU Snitzer Diabetes Health Center to launch a program at one of our Aero Dental locations to demonstrate the vital role that the dental profession can play in screening for a chronic condition. So our clinicians will be providing A1C screening, and as appropriate, we'll be referring that patient to primary care for diagnosis and treatment. We'll also be capturing certain clinical and patient data that the team at the Diabetes Center will analyze with the goal to publish results. And assuming success, our intention is to replicate this in our other clinics. Go ahead and go to the next slide. And one more. Thank you. Continuing in the theme of innovative partnerships, I'm so happy to highlight the work of the Tooth Taxi. The Tooth Taxi is a Dental Foundation of Oregon program. It's a state-of-the-art dental clinic that travels to schools across Oregon and has been providing free care to uninsured and underinsured kids since 2008. And it began as a result of the partnership between the Dental Foundation, OEA Choice Trust, and Moda Delta Dental, which was back then in 08, ODS, and I love our old logo, so I threw that up there. Each of the partners recognized the devastating impact dental disease can have on kids. At the time, it was estimated that 5,000 children suffered through their school day with dental pain. Dental disease continues to be more prevalent in children than asthma. And anyone who's ever had a toothache knows that dental pain can be uniquely miserable. It's really hard to sleep, hard to eat, and if you can imagine being a kid, really hard to concentrate on learning. A study out of California found that students with toothaches were nearly 4 times more likely to have a lower GPA than those with good oral health. Pardon me. Further, young children often struggle to communicate about dental pain, so it can manifest instead as like restlessness, hyperactivity, and behavioral issues. And as you can imagine, this can be really disruptive in a classroom. So the founding partners were committed to helping address the situation. In addition to significant financial support, they have been essential to the lasting success of the program. OEA Choice Trust opened pathways for scheduling and communicating with schools. Awareness and trust in the program was built as a result. Delta Dental has provided ongoing funding, and we do the oversight of the daily clinical operations. And this is, for me, one of the best parts of my role here at Delta Dental. Go ahead and go to the next slide. So the picture on the right is of our brand new dental van, the new Tooth Taxi. It was just launched last February, replacing our original one. The van is staffed with a full-time dentist, 2 dental assistants, and our program manager. And that small team has been able to accomplish amazing things, as you can see from the results on the slide. Each Tooth Taxi visit at schools typically runs for 1 week. And while on site, the team provides comprehensive dental services. The staff begin the week by screening and applying fluoride varnish to all the kids who have a signed consent packet. The team schedules kids by prioritizing anyone in pain or severe needs. And in many cases, they're actually able to complete all the restorative and surgical care. Being on site at a school lends itself to efficiency. If a scheduled kid is absent for the day, the team just moves on to the next child. There's no disruption due to no-shows or cancellations. And I'm so proud of what this program has accomplished. A staggering $9.4 million in dental services have been provided. The map on the bottom, I use it a lot. It's very out of date, but I just like the fact that it shows how we really are a statewide program. When it was retired, our original van had traveled the equivalent of over 3 times around the circumference of the earth, but all within the state of Oregon, which I just think is really cool. Go ahead and go to the next slide. So the team often weekly receives notes like this from kids. The interior walls of our van have tooth-related artwork all over that kids have shared during visits. School faculty and staff have been incredibly supportive of this work. They often help identify the kids that have the dire needs, but who haven't yet turned in the consent packet. So they often will reach out to those parents or help us get connected to get the consent paperwork filled out. Okay, go ahead. One more slide. So the children's program was born as a result of the experiences of the Tooth Taxi. Shortly after the Tooth Taxi launched, we realized that not all students who needed treatment were able to have everything completed during the time the van was visiting. And while some of those children had access or have access to OHP coverage, there were many who had no insurance at all. This is all pre-Medicaid expansion. So there were many, many more uninsured children at the time. The children's program was created to provide coverage of basic dental services to those uninsured kids. And this was done in partnership with the Dentists of Oregon, OEBB, and then ODS. Eligible children receive $800 of coverage per year of enrollment. Once enrolled, my team matches the children to a participating dentist to them. It is a unique network that supports this. And the program is funded by a withhold on all OEB dental claims. And then we, Delta, my team, we administer the program for free. 100% of the withhold is used to pay for children's care. So if a teacher, a school nurse, pediatrician, hospital ER, or county health department comes across a kid with dental needs, they can be referred to the program. Our two taxi staff can also make referrals in. These referrals come to my team, who screen it to ensure eligibility requirements are met, which are very minimal, that they are uninsured, that they fit the age range, and that they are an Oregon resident. Citizenship is not required. And then we match the child to a participating dentist. There's no fee to the patient, zero out-of-pocket expenses for the family. And since the program began over, well over 5 million in dental services have been provided. And that is my last slide. I'm happy to take any questions.
Opening the floor up for board members on Delta Dental and their programs that they're taking. Do you know how many kids are in the children's program per year, average, roughly, that you service?
Yeah, it has, with Medicaid expansion, it has decreased over time. When I looked yesterday, I think we have about 200 currently enrolled right now.
There's no question that the top two Pareto items affecting education of children, in our public schools is eyeglasses and dental care. That, without question. I mean, that's by far the largest Pareto items, and both of them discussed today as important critical factors in educating our children. Dr. Laura.
I think somebody is before me.
Oh, I see. Now, hold on. I just got it. My screen just cleared. Michelle first, then Dr. Laura.
I just want to say this is really heartwarming and an incredible program. Wow, congratulations.
It's a great partnership for sure.
Dr. Laura?
Yeah, thank you for the presentation. My question will be, do you have any expansion plan for this 2025 with this tooth taxi that I think is amazing?
Well, I don't know about expansion because the capacity, we just work our best to make sure we have a very full schedule, which especially after the pandemic, many schools have been waiting for us to be able to come back. The foundation at this point, mainly limited by funding, doesn't have the capacity to add a second van, which might be what your question was trying to get at. The foundation board, I'm a board member. It's something that's on their mind, but they're just limited by funding.
I see, because I see the Eastern Oregon area is gonna really uncover, so that I was wondering that, but thank you for the clarification.
Well, and thank you for that, because underneath our other community programs, we are wanting to expand. We have very aggressive ambitions for expansion in those programs separate of the tooth taxi. So thank you.
So maybe I'll give you a chance to ping some advertising here in front of a medical audience or an education audience. So you're on the board for the Dental Foundation of Oregon. What's their primary funding? How does it work? Is it all donations or is it grants? How are you funding this operation?
It's both, but the tooth taxi itself, the foundation has other things, other endeavors as well. But the tooth taxi is its marquee major program. Delta Dental of Oregon is its most significant sponsor at this point, but they do apply for grants as well.
Do you know what their annual operating budget is? Not capital. Not the bus, just their annual operating expenses to take that bus around the state every year.
I'm not good at
Roughly.
math on the fly, but I can tell you it runs about $40,000 a month.
Okay, that's good. Thanks. So $500,000 a year to run that bus around and the other things that you do, right?
Yep.
So, all right. For those that love this program like I do and others, this is how you contribute through the the Dental Foundation of Oregon, if you want this process to grow.
For anybody
Um,
directly involved in a school that is interested in a visit, just reach out to me and I can connect you into how we get things scheduled.
Excellent. Michelle, is your hand still up or is it re-upped?
No, I'll take it down. Sorry.
Oh, okay. Sorry. All right. Anybody else have a question? Delta Dental, Dr. Baricello? Looks good. All right. Really appreciate that. All good information. Thanks for all that update. Really helpful. Looking back at Mercer, Aaron, we're way early, not way early, but we're early. Aaron, are you around?
Yep, I'm here.
All right. Let's go into the vendor satisfaction survey.
Great, thank you. And Cindy, I think that you're going to kick it off.
I am. Thanks, everyone. And I just want to say, Dr. Baricello, that is an awesome program. We love to hear about it, and it's a tough act to follow those cute little faces and kid artwork. So, but we'll do our best. We are going to talk, and when I say we, it's really going to be Aaron and Teslin mostly, but about our customer service results. I just wanted to kind of give a brief overview and note a couple things. Previously, we've done this survey. We've kind of separated it out and done a customer service survey independent of the vendor partner survey. We combined them last year. There's a little bit of survey fatigue. There are a lot of surveys going around. We had a well-being survey. So anyway, we combined them this year. So the other thing I want to point out is the response. The responses are quite a bit lower than they were the prior year. So in 2023, we had 9,300 about, and this year, only about 3,800 combined. So I think Aaron and Teslin may talk a little bit about that and maybe the possible reasons for that. We think it's possibly because the survey is longer because it's combined. We've also, I think, increased our RealD SOGI demographic information, which also lengthens the survey. And then along those lines, there are people who get to that point in the survey and say, you know what, I don't want to answer all these questions, and they just stop. So those are possible reasons. It's really hard to say. Mercer has sent out emails with the survey in it. We sent our own emails thinking maybe if they get it from us, they'd respond. And we just didn't have a lot of success with that this year. So we're looking into that, but I just wanted to point that out to you in case you're curious why the number of respondents is so much lower this year. So with that, I will let Erin take it from here. She'll do an executive summary kind of results, and then Teslin's really going to get into the details. And feel free to ask questions along the way. And if you have suggestions, we definitely want to hear it. I know when we met in person, there were some who had some suggestions, and maybe some, especially on the vendor partners side of it. So if you do, please let us know. And with that, Erin, go ahead.
Thanks, Cindy. I don't really have anything to add related to the participation rates other than to say that we are thinking about ways to address that participation rate since we've seen it trending down over the last 1 or 2 years. For example, we send out the monthly newsletters, and potentially we could include a pulse survey as part of those monthly newsletters rather than going out with a survey that has, 20, 50 questions in it. So we are exploring opportunities, also trying to figure out why, although so far we just have, just ideas. We don't have any concrete information about that. So all right, so we'll jump into the executive summary here. So just want to say that this is for part 1 of the survey, so customer service. This specifically was looking at OEB staff and interactions with OEB staff, the communications that's provided by OEB, also OEB provided benefit materials like the website, and last but not least, the benefit site, the benefit enrollment site, so oebenroll.com. So for all of these, well, first I'll start, sorry, on the left-hand side with satisfaction with OEB staff. So you can see that the majority of members are satisfied with the service that they receive from OEB staff. The numbers are slightly lower than we have seen in the last year, but generally speaking, they are aligned with what we've seen in the past. So you can see that, you know, they find staff helpful, they provide timely services, they believe staff to be knowledgeable, and that they find staff provides correct information on the first attempt. For the communications, some of these numbers are slightly higher than we've seen in the past. Some of them are slightly lower. So generally speaking, they've aligned with what we've seen over the last couple years. So, you know, people have high satisfaction with the methods of communications and also with the frequency and the content and the effectiveness of communications. I do also want to point out that last stat there about 75% preferring email communications. Wanted to call that out specifically because I think OEB throughout the year does get feedback. You'll also see this when we look at the member comments that they get too many emails from OEB. So we get those comments, but yet regularly on the surveys, the preference for communication methods is email, and it's pretty overwhelming actually. So just wanted to highlight that for everyone. And then last but not least on the customer service part of the survey was the satisfaction with the OEB website. So you'll see that people are generally satisfied with the website. These stats do align with what we've seen in the past year, although I want to point out that the content of the website is about 6% higher than what we've seen in the past, which we think is great news because there has been attention over the last year on the website in terms of organizing content, trying to make links easier to, or fewer clicks and make materials easier to find. So I think these are good results here about the OEB website. So I'll keep going, but if there's any questions, please raise hands or pop into the chat and we'll address them. So then on the next page, we have the executive summary of the vendor partner survey. So this was part 2 of the survey. This covers the services provided by the vendor partners. This included costs of services, the vendors' communications, being able to schedule appointments. And this specifically covered the medical, dental, and vision plans, and then their well-being programs as well. So for the healthcare vendor partner, so that's here on the left-hand column, you'll see that most respondents are enrolled in Moda Health plans or Moda Health medical plans, in dental health / Moda Health dental plans, and then most were enrolled in the VSP vision plans. Respondents are generally satisfied with costs. They're also generally satisfied with the customer service and the communications, and specifically the vision plans received the highest satisfaction ratings. These results are similar to what we saw in the 2023 survey. In the second column there about care from providers, most respondents were able to receive care within a few months or received care every few months or yearly. And they also had positive experiences when they did receive care. So they were able to find care in a convenient location. They were able to schedule in a timely manner. They thought communication was good. And then that they felt that they were included within care decisions. And again, these are similar to results that we saw in the 2023 survey, although I'll note that based on feedback from the 2023 survey, we have broken out some of these questions into broader categories. So instead of asking about care generally speaking, we're asking about, primary care, care from a specialist, mental health and behavioral care. So we have that broken out a little bit, and Teslin will go into those more detailed results. In the third column, we did ask some questions around telehealth, how people felt about telehealth, how they were using telehealth, and the majority of people did not use telehealth, but those who did use telehealth found that the care was consistent with what they experienced in in-person visits, but yet would choose an in-person care visit over telehealth. And again, those results are similar to what we saw in 2023. And then last but not least, we have the well-being programs on the far right. And you'll see as we get into it that most respondents did not know about programs or knew about programs and chose not to use them. So that continues to be a communication opportunity for us. And so that's how we like to think about it. And we'll talk more about that when we get into those survey questions later. But that's it for the vendor partner questions. Now we'll go on the next slide into comparing the respondents to the general population. So we're able to compare some demographics against the general OEB population. You can see for gender that more females than males participated in the survey. This aligns with the general population. More members who are aged 18 to 44 participated in the survey. Now that's at a lower rate than those ages 45 to 64. But again, that aligns with the OEB population. And then survey participants were most likely to live in Marion County, Multnomah County, or Washington County. And again, those align with OEB's general member population. I did also want to point out, I know Cindy alluded to this, but as part of the survey, we did include the questions, the Real D and SOGI questions. So those deal with questions on race, ethnicity, language, disability, sexual orientation, and gender identity. These are questions based on legislative recommendation. So those were included. Note that all questions, including demographic questions, are optional. So people are not required to answer them if they don't want to. So we do have more demographics to be able to look at related to the responses on the questions. Also behind the scenes, we're using a new we're using Tableau, which is a new program for us, but we're using that behind the scenes, and it allows us to have use additional analytics so that we can better summarize data points for specific demographic groups. So given the increase in demographic questions, we felt like that was a good change, and so that we could cut data different ways as needed. So any questions so far? Otherwise, I will turn it over to Teslin to get into the detailed responses.
I have a question.
Yes, please.
So language access for the survey, it was in English and what other languages? Probably format is just the original
Yeah,
English.
I was like, I think Cindy's going to take it.
Yeah, okay.
I'll answer that. This year, actually, it was just in English. That's the only option we had. However, we're very excited to report that we just upgraded our SurveyMonkey subscription, and next year's survey, we will be able to offer, excuse me, in a variety of languages. So I believe, Erin, correct me if I'm wrong, that a member can choose which language. There will be a drop-down menu, and they'll be able to choose which language they want to see the survey in. So we're excited about that. Unfortunately, this year we just had English, but going forward, it will expand. So
that's awesome. Thank you.
And for this survey, we do always include communication and a link to a language interpreter. So if there is someone who's trying to take the survey in a different language, we make sure to always provide information for that. But luckily with the new SurveyMonkey tool too, we'll be able to just offer it easily with a click of a button. So that'll be great. Thank you, Cindy, and thanks for your question. So I'm first going to go through the customer service member survey responses, the customer service member responses. I want to highlight quickly that Erin did an executive summary for the entire survey that we asked. We asked quite a few questions. So just for your all's knowledge, we did synthesize that data. So we don't have an exact slide for every single question in the survey, but we'll be speaking to the points, and it's generally the same themes throughout that Erin already highlighted. So this first part, obviously, will go over members' interaction with OEB staff. And so quickly to orient you, because a lot of the slides coming up will look the same, we have the graph in the center of the page, which details the responses for a given question. And the question is, bolded at the top of the slide here. And then we also have a key takeaways box so that we can easily draw conclusions from the data that we're looking at. And so I'll just be walking you all through these various questions so that we can really dig into the specific data. So on this first question, you can see we asked, have you contacted OEB staff for any reason within the last 12 months? It's pretty obvious on the bar to the right that most respondents did not actually contact OEB in the last 12 months, with 71% saying no and 29% saying yes. And this is pretty typical to what we've seen in the past, so not surprising that a large number of survey participants didn't actually contact OEB. And then if we go to the next slide, for people who did contact OEB, we asked them how they went about doing so and checking any communication channel that they did use in the process. And so, as Erin highlighted, email is often a preferred communication channel to both contact OEB and to receive communications from OEB. But phone call is by far the most popular here. You can see most people leveraging phone calls to contact OEB staff for any questions that they might have, with email being the second, and then in-person fax and mail being not used very often, which I think is not surprising to see. And these results definitely align to what we've seen in prior surveys. And then if you go to the next slide, we asked for people who contacted OEB what they actually were asking staff about. And as Erin alluded to, we changed some of the breakdown of this question a little bit to dig into some details. And so we had seen in previous years that benefits questions or information was often the top comment for people that they were asking about. So this year we actually split benefits information into medical, dental, and vision benefit questions to try to look at this. So you can see here by far the most benefit related questions are specifically related to medical information, with then dental being the third popular and vision only being about halfway up at 10%. And then the second most popular topic was around open enrollment questions and plan choices. Obviously, it's no surprise that there might be an increase in phone calls or questions during the OEE season. So this aligns to what we would expect to see and what we've seen in previous years as well. And then if we go ahead and move to the next slide, we asked people next about rating their customer service interaction with the actual staff that they were in contact with. And so we ask about these key categories across the x-axis. And so we ask about timeliness of the services that are provided, the ability to provide services correctly, the overall helpfulness of the staff, their knowledge and their expertise, availability of the information, and then just overall service and satisfaction. And so you can see these really high green bars. It's exciting to see people so satisfied with interactions. No surprise at all, given the staff that's working. And these are actually similar to what we've seen in 2023 and in previous years. So exciting to see that overall service is really high, and the highest categories specifically being timeliness, helpfulness, and knowledge and expertise of staff. And then we can go to the next slide. The next section of the survey, we asked people about communications from OEB and how they prefer to receive information. And so we were able to let them check any that apply, because we know that maybe people prefer different modes of communication and different methods. You'll see here that Erin highlighted earlier, emails are by far the most popular way to receive information from OEB, with the website being the second most popular. But I want to draw your attention over to the right side of the graph. And so you'll see the wellness guide, the online comparison tool, and explore your benefits. Those are newer digital education tools that OEB has been working on and developing and put out over the past few years. And so we've actually seen those tick up since they've been created. And so it's exciting to see that there's like a third of people who are actually preferring that method of communication to receive information about their benefits. So we're happy to see that and hope that it continues to tick up in the future. But overall, pretty similar responses to what we've seen over the years. Any questions? That concludes the specific customer service interaction questions that we asked. But if not, I can go ahead and move on to vendor partner survey responses. Yeah.
Yes, hi, Enrique, good afternoon. I guess my question is, we see a decline of the participation, and I was working with your team on how we can get more members engaged. And some of the feedback that I receive is that the survey is usually sent at the beginning of the school year when everybody's enrolling for their healthcare benefits. And for a lot of our members, some of the feedback that I received was like, it's just overwhelming to just get the survey when we have a large sort of like high demand of other requests. So I was wondering if you're in the team has thought of doing this in a different way or in a different timing. I'm happy to, work with your team and maybe come up with a marketing campaign or some sort of comms campaign that we could push this out. Because I know I'm getting engaged towards the end of the survey, but I just want to put that out there that I see the low enrollment. I think we should do something a little bit different. I'm not criticizing by all means. That's all.
I think that's a great idea, Enrique. We historically, that has been the month that we've done the survey. We are definitely open to moving that. We'd like to have more responses also, and I'd be really like to work with you and figure out how we can improve the results for sure. Yeah.
Yeah, thank you so much for bringing that up. I think historically it's been easy to ask at that time of year given OEB's plan year cycle. So we want to be kind of fresh off the year that they were maybe using those given benefits. But I love that idea. And we've even been brainstorming as a team ways to do shorter pulse surveys and ways to just kind of get people's information in the moment. So it also doesn't feel like you said, an arduous thing that's another thing that goes on their plate during a really busy time of year. So thank you so much. And that's really exciting to think about working together in the future on that to increase the response rate. Thank you. If we could go ahead and go to the next slide. So as I mentioned, this next section of the survey will be on the vendor partner questions. So just to remind you, this is asking OEB members about their specific interaction with their insurance plans or their medical, dental, and vision providers. You could go to the next slide. So this is specific to MODA plans, but for your background, we asked people in the survey to select their actual medical, dental, or vision plan provider, who they're enrolled with, or if they're not enrolled in a specific OEB plan. So then once they had selected either MODA or Kaiser, for example, for medical, we also asked them to identify specifically which plan they were enrolled in. So you can see here that most respondents are enrolled in MODA Medical Plan 1 with the low $400 to $1,500 deductible. Because the districts do choose the plans offered to members, we surmise that employees will typically choose the plan with the highest benefits that's available to them and within their budget. So because the choices we know vary by entity for OEB, we don't necessarily want to draw any specific conclusions from this exact data, but this is a new question for us this year just to add an additional layer to our analysis to see if there are additional cuts or things that we can look into by specific plan that they're enrolled in. Again, I want to draw your attention to the right side of the graph. We were definitely surprised to see that 20% of people reported not knowing their specific plan. But we hypothesized that maybe that's because they're taking a survey really quickly and they don't know it off the top of their head and they're kind of going through, or perhaps they actually know their deductible amount. They definitely know the plan that they're enrolled in, but they haven't referred to it, or they don't specifically know that it's called Plan 4 or Plan 6, etc. So that was surprising to see for us, and we'll definitely keep tabs on that in the future, but there's probably some reasons why they might not know in a given moment when taking a survey. If you can go to the next slide, please. So this slide is specific to Kaiser Permanente. So this is, again, people who selected Kaiser. We then asked them to select the specific plan that they're enrolled in. And so over to the left-hand side, you can see most Kaiser members who took the survey are enrolled in Plan 1 with no deductible. Again, we're assuming that employees are typically choosing from the options available to them the highest benefits within their applicable budget. We see, again, the 28% saying that they don't know their specific plan, likely due to what I just highlighted on the previous page. But this will be helpful for years to come as we see if enrollment changes in specific plans or if there's different questions that we can cut data by enrollment plans. And then let's go ahead and go to the next slide. Thank you. Next, we asked them to rate their level of satisfaction with their medical plan, their dental plan, and their vision plan. So this slide is specifically for overall satisfaction. And you can see that a lot of people, again, the green bars are really high with people being very satisfied or satisfied with their overall OEB plans. We also did ask specifically about satisfaction with costs. And so we asked about premiums, we asked about out-of-pocket costs and covered services. As I mentioned before, we don't have a specific slide on each of those cost details, but the results are pretty much generally aligned with satisfaction across costs with this page. So you can kind of glean that satisfaction with costs and overall is in the 70s and 80s, so pretty high. And we actually saw that the satisfaction overall increased slightly from 2023. So that's great to see, kind of coming out of maybe the more pandemic years, that people are using their plans and satisfied with them. And then if we go to the next slide, we asked about customer service, so their interactions with their vendor partner, their insurance plans in overall service. For this slide, we also asked about customer service specifically in terms of how helpful they were, if they were correct, the timeliness of addressing a specific request, the knowledge and expertise, and also the availability of information. Again, we don't have a specific slide, but those results are generally aligned to what you're seeing on the page here. And you can see that customer service results are really high in the 80s and 90s. Most people are overall satisfied, and satisfaction also increased since 2023. So that's exciting to see those numbers tick up. And if you, excuse me, if any, you could, thank you. Next, we asked about finding medical care and scheduling appointments with providers. So the next like 6 or so slides are going to detail finding medical care. In previous
Michelle has a
surveys,
question,
Yeah.
quick. if
Yeah,
you
oh, sorry,
mind.
yeah, go ahead.
Thanks. Just going back to the slides about cost, satisfaction with cost. For every year I've been on the board, I've asked the survey to include a question that gets at whether or not people are experiencing or like using their health plan, because most of our members are not interacting in a very deep way with their health insurance. I want to see members who have chronic illness or who have an illness or an injury that requires a high level of interaction with insurance companies. I want to see if they're satisfied with cost. And I'd also be curious to see the satisfaction with, like specifically that you mentioned around out-of-pocket costs for deductibles and the out-of-pocket maximum and copays. I'd be really curious to see, to be able to slice all of this data so that we can just look at the people who use their insurance. That's what I want to see.
Thanks, Michelle. We're taking note of that. And we'll look into adding some questions that get it specifically at those 2 points.
Thank you.
Yeah, thank
Thank
you
you.
for highlighting that. Great. Well, as I mentioned, the next few slides are going to specifically cover people finding medical care and then their ability to easily schedule appointment with providers. So in previous surveys we heard your feedback that it might be beneficial to break out medical care into primary care, specialty care, and behavioral health care. So this year we actually did separate those medical categories to gain some further insights into, again, how people are interacting with their insurance plans and what kind of care they're getting each year. So this slide is specific to primary care, and we were asking if it was easy or difficult to find care in a location that was both convenient and desirable. And you'll see to the left side of the graph, most people are responding that it's very easy or easy to find care, with fewer people responding that it was difficult or very difficult. In 2023, again, since this is a new kind of breakout, we don't have a year-over-year comparison, but we'll be interested to see over the years if primary care roughly stays the same. If you move to the next slide, we asked then specifically about finding care for a specialist. So this we specified in the survey. We gave examples of like an ear, nose, throat doctor or an orthopedic surgeon, just to jog people's memories of what really specialty care might look like. So you can see the responses vary a little bit more when we switch over to specialty care. So we still see about half the people saying that it was very easy or easy to find care in a convenient location. But then we do see the other 50% roughly being split between either not applicable, and then also between difficult and very difficult. And so not like with NA, we might assume that people just aren't actually using specialty care or haven't interacted with a specialist in a given year. But then we do see roughly about 30% saying that it is a little bit harder to find medical specialty care when they are looking for it. And then lastly, for medical care, if we switch to the final finding care slide, we see that the numbers change a lot here, with a lot of people, 52%, saying that for behavioral and mental health care, it was not applicable for them to be finding care in a convenient and desirable location. So again, we're probably assuming here that people just aren't using that service in a given year, or they weren't trying to find that specific medical care. And then for people who did actually use it, the results are mixed, whether it was easy or difficult to find care in a convenient location. And then on the next two slides, we also asked
Sorry,
about
Teslin.
Yep.
Sorry, Michelle.
Oh,
I just
sorry.
wanted. Did you have an additional question, Michelle, or
No,
just
I'm
so I wanted
sorry.
to make sure.
I
Okay.
keep forgetting to take my hand down.
Yeah, no worries. Thank you.
No worries. Thank you. And then on the next slide, we also ask about dental care. So you'll see here that people say that it was very easy or easy to find dental care. So that's really exciting. And this is what we've seen in the past few surveys, that very few people are reporting it to be difficult, and only about 10% saying NA. And then lastly, for finding care on vision care, the results are the same. You'll see here that people are mostly saying very easy or easy to find care for vision, with a higher percentage, 18%, saying not applicable. Again, likely because they're not using this service during the 2023-24 plan year. So with that, we'll move to the next slide, which asks a little bit further about if people were able to schedule an appointment with their specific medical provider, how quickly were they able to do so? So here we're looking again just at primary care, which is where we saw maybe the most amount of people interacting with a primary care provider. And so you'll see people were able to schedule appointments pretty quickly. So the majority are within 3 months, which is typical to what we've seen in the past. And then there's only 6% of people who say that reporting that it took them more than 6 months to schedule an appointment with their primary care physician. And then if you move to the next slide, this is specific to specialty care, finding an appointment or scheduling an appointment. You'll see that they're pretty much the same. The majority of respondents were able to schedule an appointment for specialty care within 3 months or less. And then again, a very few percentage of people that took 7% of people for which it took more than 6 months, which is great to see, because maybe sometimes people will say that it's harder to find specialty care, but we're not seeing that in the survey results. So we were happy to see that, with, again, a large number here of people saying not NA because of the fact that they probably didn't seek specialty care during the plan year. And then the last slide on scheduling an appointment, this is again for behavioral and mental health care. It aligns with what we just saw for this slide before, that 67% of people are saying NA for seeking mental health care. Across the board, for people who did actually seek it, most people are able to schedule it pretty quickly within 6 months. Only 6% are saying more than 6 months. But again, it's looking like at least a lot of the survey respondents weren't visiting a mental health or behavioral health provider during the plan year. And then I think I see a question.
Yeah, Cheryl had a question.
So real quick, thank you very much. One of the questions that I have is, so these results look really good. But in comparison to like maybe the last 3 years or so, are we getting better, or are we, is it easier to get a doctor's appointment? Is that getting easier? I guess I'm asking those sorts of questions just because I think that the results are great, but I wonder how they compare.
Yeah, definitely. As I mentioned, so for medical care, because we've just looked at medical in general as a category before, we don't have that exact year over year. I think medical primary care, which is maybe what people would associate, we've seen that pretty standard, like pretty easy across the board over the last few years to find care. But then for dental and vision, I think in the previous years, I know that during COVID and the pandemic, we've been seeing a trend upwards for vision and dental overall. Definitely not anything getting worse. So there's been no decrease in the ease of finding care, but I wouldn't say a huge uptick either.
Yeah, and just to confirm, we hadn't previously asked about specialists and behavioral health, mental health. So that those are the two that we can't say specifically how they align to last year.
Okay, thank you.
Of course. Thank you for your question. And then the last two specific survey slides that I'll present on are about well-being programs. So you'll see here lots of different colors on the graph. So we're asking about people, excuse me, we're asking people to rate their level of satisfaction for a specific well-being service or program. So you'll see across the bottom, personalized health assessment, personal health coaches, gym memberships and discounts, and tobacco programs. And we ask people to just rate their level of understanding as well as their satisfaction. And so here you can see the orange and purple bars are quite high, showing that a lot of people are either did not know that the program existed or they knew about the program and actively chose not to participate. If you look to the right for tobacco programs, I think it's no surprise that the purple bar is so high, given that this is such a specific service, but maybe one that a lot of people know about. And these results are pretty similar to what we saw in 2023. And then if you go to the next slide as well, we asked about diabetes management, physical therapy, emotional well-being support, and weight management programs. And we see that same trend in the orange and purple bars being that most people are saying that they either didn't know about the program or they knew about the program and chose not to participate. As Erin alluded to earlier, OEB really continues to highlight and advertise well-being programs through various communications. So we see this as an opportunity. Even OEB has an online digital wellness guide that highlights all of these different services. And so members can go to that guide anytime and click by a specific wellness offering, find how to access it, find how to log in, find what's available to them. So we plan to highlight this specific well-being resource a lot in 2025. And then additionally, in the 2025 monthly newsletters that will start coming out this year, they'll be focusing on specific different medical conditions. And so in those newsletters, we'll be able to provide opportunities to highlight the associated well-being programs that might be for a specific condition. So hopefully through 2025, we continue to see people engaging and learning more about the well-being programs that are offered to them. With that, that concludes the specific survey graphs that we'll be looking at, and then I will turn it back to Erin, who will go over kind of the open response comments that we got as a part of the survey.
All right, thanks. So as Tesla mentioned, we did have a question at the end that just said, tell us more, anything you want. And we did receive 704 write-in comments in that question. And this page here summarizes the top quote unquote positive responses that we received. You can see the different categories there, and then the numbers in parentheses indicate the number of comments that we received for that specific topic and then related to the specific comment. So around member services, we received 32 comments about that. The top responses were something along the lines of good service and keep it up, and also that member services is helpful. On coverage and benefits, we received 39 comments related to this, or 39 positive comments, with the top responses being, we have good coverage, no complaints, there's good dental options, we have good quality of healthcare, benefits. There were 2 comments around premiums and costs, which are there, affordable and good price or low cost. And then there was an other positive premium cost comment, which we weren't able to really classify. So that's included there. Around enrollment, there were 4 positive comments, 3 around enrollment being easy, and another kind of other enrollment question or comments. And then last was a miscellaneous positive comment. We had 10 of those. Generally, people were happy, satisfied, or said something along the lines of everything is good. And then also just kind of that like general miscellaneous comments. So those are the top positive comments. On the next page, we have the top areas for areas for improvement. And again, this is out of the 704 written in comments. The topics were member services, information, enrollment, premiums and cost, and coverage and benefits. So 28 comments around member services with areas of improvement around being given inconsistent or incorrect information, poor service, or that the customer service needs to improve, or that there was that the staff was not knowledgeable or that they were unable to answer questions. Around information, we received 45 comments around that, with the top comments being around getting too many emails, messages, and advertisements, and just included that just because we know the preference continues to be email based on what we see in these surveys. Information's hard to find. We received 15 comments around that kind of topic, and that the website is hard to use or navigation is hard. In enrollment, we received 17 comments around that, with the top comments being around would like to be able to switch, and this is specifically insurance companies, sometimes related to open enrollment there. And to be fair, some of the comments that come in are kind of hard to interpret or understand sometimes, so that we do our best to categorize them together with like comments. The other comments were around the open enrollment website being difficult to use, or that they don't like the timing of when open enrollment is scheduled. There were 135 comments around premiums and costs, about premiums being too high or wanting to reduce the amount of premium costs, that out-of-pocket expenses were too high, and that the deductible was too high. And last but not least, we have coverage and benefits with 224 comments around that. The top comments here were around physician access issues, gym, fitness, and wellness coverage issues, MOTA being difficult to deal with or providing inaccurate information, doctors being out of network and would like more provider options, and then feeling like the level of benefits had been decreased over time or want increased benefits. I will say for both the positive comments and the areas for improvement, these are very similar comments that we have received in the past. The amount of comments received, as well as the topics that you're seeing here on the previous page and here, are consistent with what we saw in 2023 in the vendor partner service survey, as well as the last few customer service surveys. So that is our final slide that we have with details. Cindy, is there anything that you wanted to add about any of the results or generally, or the general survey comments?
I just want to add, as we look at these write-in comments and we look at the results, keeping in mind that we have 60,000 about members, and we get just a small percent of people who, even when we have 10,000, it's still a relatively small percent. So when you start looking at, I was thinking about it as I'm looking for room for improvement opportunities. 8 people out of 60,000 saying, "Hey, I didn't get good services." I just want to make sure we recognize that these are really small numbers in comparison to that. And believe me, when people are not happy, we hear from them, even if we don't hear from them on these surveys. So as a whole, the staff from our benefits team to communications and everyone does a really stellar job. And I just like to take this opportunity to let you all know that we get positive feedback all the time from our members too. And I'm going to beat Ali to the punch because he always uses this as an opportunity to say the same thing. So anyway, if you do have questions or, suggestions, additional suggestions for what we can add to the survey, let us know by all means. We do try to keep it as streamlined as we can so that we don't have members, walking away in the middle of a survey. So anyway, we're happy to hear from you. So thank you.
Thanks, Cindy.
Open the
I
floor.
don't see anything in the
Anybody
chat. Yep.
else, from the board want to raise their hand? Don't see any. All right then. Thanks for the update on the survey. And, for me, this kind of numbers are pretty standard over the years I've been watching this. And I know I get way too many survey questions. Everywhere I go. I took my truck in for service last week, fill out a survey. I went to Best Buy last week, fill out a survey. I went to Jamba and I got a survey. Just you just start ignoring it. It's hard to do it, especially when you get one that's more than 5 questions. It's just kind of, yeah. So difficult in these times, but I think people are starting to get accustomed to that. But then what it motivates you to fill out a survey is not when you're just tootling along. It's when something isn't going right. So that's kind of normal and has been normal for a while. All right, I don't see any hands up. That leads me to ask Rose if we have any public comment.
No, you don't have any public comment.
I'll open it up to board members for other comments or anything they would like to say for upcoming meetings or per se. I would like to, and I don't know if he's on here, but for 8 years, I've been working with Kaiser with Dr. Keith Bachman, and he is departing, as in retiring. If I had my say, I would cancel his retirement and tell him he has to work until he's 150. But that is not the way it is, and he gets to retire. So I just wanted to appreciate the work from Dr. Keith Bachman at AMODA and all the services and work that he has provided OEB and PEB, and also in educating myself in just how things are. I remember him coming by when I first joined OEB 8 years ago, sitting in the back of the room during CL meetings and wondering things, and he would answer questions for me all the time. So that was excellent, and really appreciate all the time he has spent here and working with us here on OEB. Ali, I see your hand up.
Yeah, I just, I can't say any better than that, Bill. Dr. Bachman is such a compassionate, caring person, and we've really enjoyed working with him over the years, and he's just brought so much to both boards. And so best wishes. And we also had a quick ask of the board. We are looking for one board member for our joint health equity work group, and then one for our joint PEB and OEB innovation work group. And Roberts currently sits on the innovation work group, and Bonnie sits on the health equity work group. And if anybody is interested in either of those, the health equity work group really does important work, especially around renewal time. They vet a lot of the policies that the boards are considering, making sure that they meet health equity standards that the boards have prioritized. And we've developed tools that they use and can provide the boards with a health equity assessment. And the innovation work group has really been a boon for both boards. It's kind of, it came out of Senate Bill 1067 that we talked about earlier, and have really done a lot of great work around leveraging the data of both boards, which is extremely valuable, looking at cost containment measures, looking at future kind of planning on how to maintain benefit levels, but manage costs. And so speak up now or send me an email. Either is fine. We can definitely provide more information to you, like frequency of meetings, and try and make it just least of a burden on your valuable time as possible.
Both work groups are like one meeting a month, right? For 2 hours or 2.5 hours, I think, right?
Yeah, IWG is meets Margaret. Feel free to speak up about 7 times a year. Bonnie probably has some information on Health Equity Work Group if you want to share.
Yeah, go ahead, Bonnie.
I'll be just gonna say, I just attended the 2 meetings so far, but I kind of find it really interesting and beneficial to know some of the information that they're looking at as far as the equity is concerned. But they do have 2 people from PEB on the meetings, and I'm the one from OEBB, but it'd be nice to have someone else. And if you have any questions and want to talk to me before you raise your hand, or I could suggest some people, So talk to me first. Thank you. I was going to bring that up, Valerie,
once
so
a
I'm glad you
quarter,
did.
once a quarter-ish for Health Equity, and once a month for IWG for 7 months out of the year, kind of in that range. That's not exact, but those are the kind of issues, right? And then, of course, come April, May, we'll have our topics for the summer work group, and we'll be asking who wants to participate in those topics as well. Thanks, Ali. I totally skipped that part. It
No worries.
pages on me, right? All right. Anybody else have anything for the good of the order? Anything else to say? If not, I'm going to give you 24 minutes of your day back. Going once, twice, sold. All right. This meeting is adjourned. Thank you, everybody, for attending.
Thanks, guys.
Thanks,
Bye-bye.
everyone.
Thank you.
Hi, everyone.
Thank you.